All right. Hi, everyone. I'm Cheyenne. I am the program manager for the South Texas Community Health Workforce Preparedness Collaborative. I'll tell you a little bit about who we are in a second. But I'm so excited to have you on today, which is our webinar on unlocking resources for community health workers. So just some housekeeping. Today's gonna be very interactive. We're gonna have two different Q&A sessions, and I want you to use the chat box. But when you're not speaking, please mute yourself. I will try to mute people who might accidentally come off mute. And then if your connection is slow, you can turn off your video. Although we do encourage video, especially if you want to come off mute to ask a question. So I will do a little bit of a background on the Workforce Collaborative, and then we're going to have three presentations. Sorry, this is getting ahead of me. So our first speaker will be Dr. Van Ramstorst, who will be speaking about the new Medicaid laws supporting CHW reimbursement. We'll have one Q&A session then, and then there'll be two more speakers, Dr. Schlenker and Dr. Earl, on their clinical and community-based approaches to CHW sustainability. And then we'll have one more Q&A session, and I'm very happy to be, and I will tell you more about them before they speak. But I'm also very happy to be joined by Dr. Julie Bazan today. She's joining us to moderate the Q&A, and she is the director of the Mid-Rio Grande Border Area Health Education Center. And then we'll wrap up. So I just want to tell you a little bit about who we are and the series that we're presenting. So like I said, I'm representing the South Texas Community Health Worker Workforce Preparedness Collaborative. We are funded by HRSA, which is the Health Resources and Services Administration, and they are investing right now in building the community health workforce across the U.S. to address health disparities, and they have four priorities: to expand the public health workforce, to increase public health workforce employment readiness, to extend and upskill, so to promote community health workers, and then to advance health equity and support underserved communities. So in simplest terms, who are we? Our mission is to increase the community health workforce by recruiting people from the communities of those medically underserved in South Texas. And our vision is to integrate those community health workers in health and social service systems to reduce health disparities. We came together with these partners. So there's several, I think there's at least 11 at my last count, to form the South Texas Community Health Worker Workforce Preparedness Collaborative, to expand and enhance this community health workforce, thus lending to a larger, more qualified pool of candidates to hire. We're delighted to be joined by employers from across the state, and we of course welcome you here. But in terms of where we provide our training and professional development, our reach is these 38 counties in South Texas, where every county is designated as medically underserved, either in part or entirely. In these areas, there's fewer certified CHWs serving marginalized and medically underserved populations living in more than 30 rural counties. The workforce is aging. The state is struggling to retain Spanish-speaking community health workers. And this is threatening a shortage of community health workers in the region. So accordingly, we are focused on recruiting young adults, Hispanic and Black adults, and Spanish speakers. Our programs are focused on training and providing experiential learning, such as through internships and apprenticeships, but we would be amiss not to advocate for CHW employment, of course, to benefit our trainees, but also to improve health equity in Texas. So thank you for joining us today. This is our second webinar in our CHW Roadshow series focused on increasing CHW employment in Texas. And so we will get started with Dr. Ryan Van Ramstorst. He is the Chief Medical Director for Medicaid and CHIP Services at the Texas Health and Human Services Commission. His work experience includes practice in underserved communities on the south side of San Antonio. He's faculty at UTESCA at the Department of Pediatrics, and he's the co-medical director of the UT Teen Health Clinic in downtown San Antonio. So thank you, Ryan, for being here today. And I will turn it over to you.
All right, thanks, Cheyenne. Well, good afternoon, everybody. Again, Ryan Van Ramshorst, Dr. V for short, Chief Medical Director or Chief Medical Officer, if you will, for the Texas Medicaid and CHIP programs at the Texas Health and Human Services Commission. Very pleased to be with you to talk about this important subject. Community health workers are on my mind a lot, but specifically this morning we had a convening of all of our Texas Health Steps provider relations team that work around the state with Medicaid providers that are taking care of kids and teens as part of our well child visit program. Many of them are community health workers. So I feel that I was in good company this morning and will be in good company this afternoon. Just a little bit about Texas Medicaid. We are the third largest Medicaid program in the country. We cover just shy of 6 million Texans, the majority of which are low income children, but we also cover adults and children with disabilities, children and youth in foster care, as well as pregnant and postpartum women. We are a managed care Medicaid state, and I believe that we will have at least a couple representatives from some of our Medicaid managed care organizations tuning in. So what does that mean? We work with Medicaid managed care organizations, otherwise known as health plans or HMOs. We contract with them to deliver Medicaid services, enroll providers, work with providers, and coordinate care for individuals enrolled in our services. I'm pleased today to talk a little bit about some happenings in the CHW space and some exciting activity that came out of our most recent legislative session. But before I get into that, I want to talk about something that I think is very near and dear to all of our hearts, and that is what we call non-medical drivers of health, also known as social determinants or social drivers of health. We certainly know that community health workers are uniquely equipped to address these issues. I always say that if I have a child with asthma and they're not able to get to my clinic to get a prescription for an asthma medication, I'm not going to be able to address their asthma. And so the agency, for the first time in the history of Texas Medicaid, has developed a non-medical driver of health action plan where we give direction to our Medicaid managed care organizations to prioritize work in this space. And the three areas that we have prioritized, and this will not be a surprise to any of you, are food insecurity, housing, and transportation. And so I'll make sure that as a follow-up, you have links to our non-medical driver of health action plan. There's multiple goals and sub-bullets that have to do with supporting providers, building relationships with community-based organizations, sharing and exchanging data, and just working to swim in the same direction. So I think that's just important for framing. So now on to our legislative developments. You may be aware that Texas is one of those states where its state legislature meets every other years. Ours meets on odd number years for 140 days during the regular session. We have an upper chamber and a lower chamber, the Senate and the House respectively, and I work in the executive branch of government for the Texas Health and Human Services Commission. And our role is to implement the legislation that our legislators create and pass, and that is signed by the governor. And there's two pieces of legislation, now law, that I would like to bring to your attention. And again, I'll make sure that you have the links to the bill text in the event you'd like to read the bills yourself. The first bill, which is the bigger of the two, is House Bill 1575. And this was authored by Representative Lacey Hull, who's from the Houston area. And this bill is really all about non-medical drivers of health and women's health. The bill does a couple things, and I'll call out two of them. Thinking about non-medical drivers, this bill directs our agency to come up with a standardized list of screening questions for when a woman would enroll in Medicaid or Thriving Texas Families, formerly known as Alternatives to Abortion. So screening questions that would screen that woman for things like food insecurity, housing insecurity, transportation challenges, issues with utilities, intimate partner violence, and that way that Medicaid managed care organization can connect that individual with services that are available in their community. So that's one thing. The other thing that is perhaps even more relevant to today's talk is about adding two new provider types to be able to bill for Texas Medicaid services. And those are community health workers and doulas. And we know from the work of the Texas Maternal Morbidity and Mortality Review Committee that looking towards other types of providers, such as doulas, is very, very important when it comes to maternal morbidity and mortality and maternal health. And so, again, this will add doulas and community health workers, and they'll be able to bill for Medicaid services through a program that is known as Case Management for Children and Pregnant Women, which we abbreviate CPW. And so CHWs and doulas will be able to bill for case management services through that program. And as you would imagine, we here at the Health and Human Services Commission are working furiously to implement this legislation. So that is the first piece of legislation. Again, that standardized list of screening questions for non-medical drivers and adding doulas and community health workers. I'll also say that we do know that many of our managed care organizations, if not all of them, have already been working with community health workers to support the needs of their members. And this second piece of legislation should make it easier for them to continue to do that. So without getting too wonky too fast, we know that if you're a health insurance company, you get a certain amount of money to manage the care for individuals, and there's something that's called the medical loss ratio, which has to do with how much profit a health insurance company would be able to make and how the finances are done. Well, House Bill 11113 by Representative Ortega from the El Paso area allows that managed care organization to count any costs working with community health workers as a quality improvement cost. And what that means is that it doesn't count against the Medicaid managed care organization, which again should theoretically make it easier for a managed care organization to work with community health workers. And so lots of excitement about that. Again, we look forward to implementing these pieces of legislation as well as everything else. Just to give you some ballpark figures, there were just shy of 12,000 bills filed in this 88th legislative session. Over 900 had to deal with Medicaid, and of that, about 60 were passed into law that we are furiously working to implement. And again, I think lots of excitement from the community about both of these pieces of legislation, hopefully making it easier for community health workers to meet the needs of Texans. And then in the last minute or two that I have, I'll make a plea to all of you. And as you may know, all Medicaid agencies are in the process of redetermining eligibility for everybody enrolled in Medicaid. And you may know that during the pandemic, because of federal legislation, Medicaid programs received an enhanced match rate to continue people in Medicaid during the entirety of the public health emergency. That has since ended. And so, again, all Medicaid programs, Texas included, are in the process of redetermining eligibility. And again, for Texas, that's almost 6 million people. So we're very thankful to the legislature for giving us additional funding to bring on additional eligibility workers to help work with Texans and process that information. But we have an ambassador toolkit for continuous coverage for folks like yourselves that has materials that you can post in client-facing lobbies, waiting rooms, exam rooms, etc., that provide critical information to the individuals that you serve. I think the most important takeaways are it is best to make sure that an individual's contact information is up to date with HHSC. You can do that through calling 211, through snail mail, and also through our web portal, which is yourtexasbenefits.com. And the second thing is that if an individual receives a yellow envelope with red writing on it, they need to respond within 30 days with that additional information so we can make an accurate coverage determination. It's very important to us that eligible Texans continue to be enrolled, but there are times when we need that additional information, and so we want people to respond. So again, if they're still eligible, they're still going to get coverage. And if they're not eligible, we can refer them to a different place, such as coverage through the health insurance exchange on healthcare.gov. So Cheyenne, again, thank you so much for the invitation. If you can't tell, I'm very excited about this work. I did put my email address in the chat. I'm a public servant. If there's anything I can do to serve you or your organizations, please do not hesitate to reach out to me directly. I'm happy to stay on for a few more minutes to hear from some colleagues, but I will have to drop off around 12:30. But just thank you again for all that you do in the service progressive Texans, and I'm excited for what the future holds.
Thank you so much, Doctor. That was a amazing news, and I know that's music to many people's ears.
Good, good.
And we now have some time for questions. If
Perfect.
anyone from the audience has any questions, please go ahead and unmute yourself, or if you would like to put your question in the chat box, you're welcome to do that. And while we're waiting for a couple of seconds for that, Doctor, this House Bill 1575 and 113, based on your experience, how long would it take for these to be, ready for us to say, hey, we can go ahead and employ community health workers and bill for their services?
So it is very difficult to come up with a specific timeline. That is a non-answer to your question. But I will say for House Bill 1575, because it has multiple components, it will take us longer. And anytime you add a new provider type to Medicaid, that is kind of its own administrative process. I think that screening question, the list of standardized screening questions, will probably be available sooner rather than later. And we're working with various stakeholder groups to help us sculpt that list of questions. But I think it's probably safe to say that with regards to the community health workers and doulas, that wouldn't be something that is implemented until sometime next year.
Very good. Well, that gives us plenty of time to certify more people to become community health workers and really expand their services across the state. So thank you so much. Does anyone else have any questions?
Yes, ma'am. Can you hear me?
Yes, go ahead.
Yes.
Hi, my name is Lorianne. I'm from Houston. I have 4 clients. I am a licensed community health worker, first of all, but I have 4 clients that have congestive heart failure. The insurance that I signed them up for, which is Ambetter, is not working for them. I have one that is in dire need of a pacemaker. So I'm kind of confused on what I can and can't get done, and how do I make sure that the companies that I'm signing them up for insurance is the right company for them. When I talk to them and drill them about what I need, it's all good until they actually get the plan, and they get there and they can't get anything done. And out of 4 people, maybe one got services. She has to have surgery. That's it. So I'm kind of confused, and
So
I don't like.
I think you cut out a
Yes,
little bit, but I was
that's
able to hear most of
when
the
I'm trying to
question.
help my client because I know that what they need.
Of course, and thank you for what you do. I believe that Ambetter is one of the products that is available through the exchange. It is not a Medicaid product. But what I would suggest to you is if you're thinking about what other options are out there to connect your clients with services, that yourtexasbenefits.com, if they fill out the information on that website, will automatically screen those individuals for services through Medicaid, CHIP, SNAP, WIC, TANF, all of those other services that are offered through the Texas Health and Human Services Commission, or it will refer them to the health insurance exchange. I think the other thing that I would suggest is, having done medical school in Houston, I do know that Harris Health operates a program that used to be called the Gold Card program that does offer a sliding scale payment mechanism for individuals under 200% of federal poverty. And that
What is
sounds like it would
that
be an
called
option.
again?
It would
What
be
is
through
that
Harris
called again?
Health. It would be through Harris Health, and it used to be called the Gold Card program, but I was in medical school a long time ago, so it might go by a new name, but it is a program operated by Harris Health, which is the Harris County Hospital District. And I'm seeing from the chat, it's still called the Gold Card. Thank you.
Yes, it's still the gold card. Okay. Thank you. Are we able to help
Does anybody else have any other questions? Let me look at the chat box really quick. Thank you, Connie, for including the link in the chat box. Well, doctor, thank you so much for your time and for sharing with us the wonderful news. We hope that this will not be the last time that you join us. And thank you so much for everything you do at the state level. We
Of
wish you well,
course.
sir.
And I'll put links in the chat, and then Cheyenne and Dr. Bazan, I will send you those links also in an email so you can distribute them to the attendees, especially for those that weren't able to tune in. But thank you again. I hope you have a great rest of the discussion.
Thank you, sir.
All right, thank you. And yeah, I will make sure to collect all resources and distribute those along with the recording. So next we have Dr. Carolina Gonzalez-Schlenker. She's an assistant professor in the Department of Family and Community Medicine at UT Health San Antonio. And in my short time at UT Health San Antonio, I have come to know Dr. Schlenker's name very well because of her support for integrating CHWs into the clinical setting. So I'm very excited to learn more about how she's done that. And I will turn it over to you now.
Yes, can I share my screen?
Yes.
Alrighty. And wait, let me just make this up again here. Sorry about this. I had a technical difficulty after I have joined the meeting that I had to deal with, and my PowerPoint closed. I need to open it again. Wait, no, I'm sorry.
No problem. And if we need to return to you, we can do that too.
Yeah, let me just see if we can get it. Okay, this is it. Sorry about that. Right. Okay. To you and share my screen. Okay, so. Okay, can you see it?
Yes, it's perfect. Thank you.
Okay, can you hear me?
Yes.
Okay, awesome. Okay, well, real quick, and sorry for the time. I know we're in a crunch here. Thanks for having me. Good afternoon, and thanks for letting me share briefly how we have been able to establish a promotores community health worker in a primary care setting. I will focus on some main ideas of, a lot of information, but hopefully I can be there. So healthcare, how we can define healthcare as our organized social response to the process of health, disease, care, right? So healthcare's mission is to care. And we care, we institutionalize care because we are vulnerable and we can suffer, we can get ill, we die. And that is our shared human condition. And if we want to hire community workers, promotores, we must be mission driven because they are persons driven by care. And that when we established our program almost 12 years ago was already present in our department, in our primary care practice. The chair of our department had been a pioneer health reformer of primary care. He was one of the leaders of the patient-centered medical home. Our chair of research had used the capabilities approach, which is developmental economics, to prove that poverty in the context of poverty prevents people from achieving health behaviors. The director of our clinic had built an organizational culture of caring that inspired our faculty, our staff, our residents. I, who came in as the supervisor of the program, had been working in trust model. So we had already this mission-driven philosophy and commitment. So what does the mission has to do with financing? And basically what it allows is to establish an order of value justification. So when we care, we want to know, we want to have the information of what's causing the suffering. And that is time one. To that information, we apply science, and to that science application is what we want to fund. So we finance that science application. So basically, money is a means to this noble end, which is the mission of healthcare. This is what inspires and drives. And if promotores and community workers believe that they're part of this, you will have their best performance. However, are we being accountable for this mission? Unfortunately, this sequence is not what's holding the system in place. It is the accounting. It is the value metric of accounting who is driving the system to the point in where time 3 is determining what happens in times 2 and basically neglecting much of what is happening in time 1. And that problem was already something we knew on 2012, where we started the program. We knew of this challenge. We knew that demands of accounting on fulfilling our accountability of the mission of healthcare. Our APC was called Advanced Primary Care, was very aware of the tension between these two metrics of value. And especially we wanted to strengthen that time 1, to have that information flow into the system, to understand how our patients were living their vulnerability so that it could inform how we were organizing workflows. And those that brought in that information and became the bridge of trust were our promotores. So these are promotores. They basically, their role as they enter the healthcare system, their expertise is that they are trust builders. They're not clinicians, they're trust builders. They know a lot of stuff about many things, but their role and their workflows are based on how much trust they can actually produce. And trust is not monetizable. You cannot ask a promotor to produce 4 trust in an hour, right? This trust has its own dynamics and its own time horizon. And the unit we use to organize the promotor's work is a story of care. This story of care can begin with our clinicians in practice or with our patients in household. But that is what makes coherent their work, is the story of care. So when you don't have something that is monetizable like that, I mean, you can ask a doctor to see 4 patients in an hour, right? You cannot ask the promoter to build 4 trusts in an hour. So we need to create a different order, a different structure that organizes their work, which is in dialogue, but not determined by the administrative forces that run the workflows of the rest of the people in the clinic. So we have to get closer to the context. And what we did is we honor existing instruments. We used the ICF for several years, which is a measure of functioning as the health outcome. We then discarded because it did not really add much to what we were focusing, which was the mission-driven care. We practice trust to expect trust. We repair breaches of trust. We had to expand the ethical framework beyond bioethics and what the institution provides to deal with the moral dilemmas that promotores bring into the clinic and into themselves. So we don't monetize their work. We have to respect the time horizon of a story of care. However, you need to measure their work, especially the density of their work, and create clear expectations of performance. You need to compromise with your employment needs. For example, the promotores are paid a salary. They have to clock as if they were in an office, entering at 8, having 1 hour out for lunch, and then ending at 5. That schedule is not what they work in, but they still have to clock. So we belong to and are paid by this corporate structure of healthcare, and we need to give what they need for us to become part of their structure, their administrative structure, without having to give up our trust building framework. So the caring practices of what becomes part of the structure of the promotor's workflow is always being updated and improved. So from these alternative order of workflow, then we can relate to funding. Then we can enter into a mutually respectful dialogue with the system of accounting. So let me tell you a little bit of what we did and how did we end up, being almost 12 years in this primary care setting. At the beginning, before the program started in 2012, our leadership had gotten closer to the patient by putting an MA who called the patients after discharge from ED visits. They gathered the data and they proved that actually the ED visits and the readmissions decrease, and that was evidence, right? From that evidence, they get funded by our county system to begin our program, and other funding that was already existing in the department for some professorships, etc. So we began then with 4 promoters and began mostly putting into place that order of workflows that I told you about. Then came this big funding from the medical waiver district, which was a redesign of delivery of healthcare based, funded by Medicare, with specific interest in prevention. So our district program was focused on diabetes, on lowering A1Cs. And again, this is the funding. They have certain requirements, certain set of numbers of patients that need to be covered. In our organic, trust building model had to enter into dialogue with the requests of our funding. Sometimes promotores wanted to keep a patient longer, but we have a set of numbers that we need to cover for our funders. Well, we needed to sacrifice certain things so that we give the funder what they need. And we were able to manage and enter into that dialogue without sacrificing the trust building or the mission driven. After the medical waiver, which ended in 2017, by the way, our action on the waiver was just published as how the promoters work lower the A1C and was at this big impact on diabetes care. But then came the new way of financing care and primary care, in where Medicare and Medicaid have these accountable care organizations, in where instead of funding or incentivizing providers by fee for service, they want to incentivize quality of care. What that means is they're focusing on prevention. So here, okay, promotores, all the patients that you see, you also are going to push the colonoscopy, the mammogram, the pap smear. All these preventive measures need to be part of your work. You're going to find a patient in crisis. Well, you're not going to address this preventive stuff right away, right? But make it part of your intervention. You navigate the trust building, but you also satisfy what the funding is giving us and needs for us to continue to be funded. So we did. We got a lot of colonoscopies done. Actually, the promotores were amazing at convincing, after they taken care of the patient and gained their trust, to say, you know what, it'd be good that you don't have cancer on top of all this stuff. Let's get you that colonoscopy, right? And that is the beauty of this trust building model is that all these other things have a room in it. And if they're going to fund things that are part of caring for a patient, we'll go for them, right? Now with this new big emphasis on the social determinants of health, and an emphasis on what we see as symptoms of a deeper problem, which is poverty. But if you're going to have patients with food insecurity, with transportation, with lack of housing, be taken care of by promotores, well, wonderful. But that does not mean we give our deeper approach to being mission-driven up. We continue having that critical positioning towards the way the system is functioning. And what we want to do is to provide alternatives. So how do we deal with these social determinants of health, which are increasing? When our social services are overloaded with requests and demands, and our waiting lists are longer and longer, right? So here is where, let me see, this is not advancing. This is where, and this is my last slide, I think. Basically, we need to design metrics for life. Once you get the information in, and that's what hiring promotores promise is this better future for healthcare? We need to make salutogenesis, the health generation, the incentive, not financial, but actually producing health and make it the metric of quality. We need to collect data on accountability as the container of accounting. Each story of care that the promotores produce includes a financial component, but is much bigger than just spending some money, right? So the story of care can be the health outcome of a cost effectiveness analysis model. This is something that needs to be explored. And we need to continue to refuse to abandon people in inhuman conditions. This is not something that promotores that work from the heart will do. So we commit to solidarity. We get the story. We can grieve, but we don't lose hope. Grief and hope can coexist. All this concept of structural injustice that we need to change. We don't like these structures. We need some new ones. Let's move from guilt to the historical responsibility of building them. And the information that promotores and CHW bring us, give us the needed variables that are at play to begin changing the structures under which we live so we can have better health. So basically the idea is help bring in our promotores, bring in that voice of caring, and bring in the information so that we can build health, community health. That's what they're good at. One story of care at a time. And I promise you, our doctors will follow. This is the latest thing on implementing high quality primary care, and our boss is deeply involved in this. Pay for primary care teams to care for people, not doctors to deliver services. So again, what is caring? What does it mean that we have as a resetting of the culture into a more caring culture? I think the promotores CHWs are our promise. And with it, I end.
Excellent. Thank you so much, Doctor. Thank you for that wonderful presentation and highlighting the importance of community health workers in the entire state of Texas, but more so in the healthcare system and how through their trust that they build in their communities, they're able to bridge services with healthcare. So thank you so much. Does anyone have any questions for Doctor? You can unmute yourself. Doctor, I really appreciate the fact that that community health workers are being recognized. I know that in a lot of the rural areas of South Texas, and I see some of my colleagues from the other AHIC programs, the community health workers have been doing amazing work for years and years. And I am just so thankful and grateful that they are being recognized, and they are placed in a position of caring, like you mentioned. Without caring, the patient will not matter to people. It'll just be another number or another illness. So you certainly delivered a lot of great information that I'm going to take to the community health workers that could not join us today and remind them that their service is valuable, not just in our community, but in other parts of the state. And good things are going to happen for them. So thank you so much, Doctor.
Thank you. And folks should continue to think your questions, because whatever time we have left, we'll have more time. Okay, so let me introduce Mr. James Earl. He's the Director of Outreach and Health Equity of Cancer Care Services. So among other things, he is a certified CHW instructor, and his passion is people. So he is always seeking out innovative ways to reduce disparities and spread the awareness of cancer care services. And James, let me switch the spotlight to you.
Okay.
And you can get started and just let me know when to advance the slide.
Okay. Thank you, guys, and thank you, Cheyenne, for that intro. I just want to clarify, I am not a doctor. I heard Cheyenne mention that earlier. Maybe one day, who knows? I don't know where my career trajectory may take me, but I just wanted to make sure I'm not credentials. But I'm going to give you guys a little bit of context on a community-based to CHW sustainability. But first, I kind of want to frame it within the context of Ag Cancer Care Services. And so we are a nonprofit based in Fort Worth, Texas, North Texas, Central Texas, that serves all of Tarrant County. We were founded in 76 years ago. We've been around for a very, very long time. And our mission, cancer patients, care for caregivers, and empower survivors to reduce the impact of county. And so we believe that help equals hope. We try to connect our clients and our families with financial help, social support, and additional resources, all of which come at no cost to the people in our community that we're. And so we have several programs that are focused on crisis help, care, counseling, and financial navigation and connecting. So with the crisis help program, financial assistance, that looks like health insurance premiums, transportation to treatment, in some cases of assistance with emergency. And then with case management, this is an intentional process where we try to reach barriers to care for people in our community and also individuals that are living outside of. So we try to find resources that can help them. And so we have an expansive of community partners and providers that serve an overlapping population to the disparities that we see with cancer in our community. And then with counseling and education, we provide our residents and our community members free counseling and help in navigating and understanding their insurance benefits. And it can be an extremely isolating disease, isolating for the family, isolating cancer patient. And so we have a set of programs that are designed to bring our families isolation to provide a form of support and care in a nurture, and to let our clients know that they are not alone. So next slide.
Sorry, there you go.
This is our outreach and health equity team. We have community health workers, some part-time, some full-time. We also have some MPH professionals as well. So a very blended staff that we have here at Cancer Care Services. Next slide. So I want to give you guys first just a timeline of events. We have comprised and put together our program. In in 2019 with the integration of, and that was done in part through a grant through the Foundation. And so we were tasked with developing partnerships and connecting neighborhood residents to cancer care services. And now those that were identified were 3 zip codes that included 1 in Fort Worth and 2 Arlington. These zip codes were historically medically underserved. And many of our clients, our community members, face transportation to getting to our agency. And so we believe by working within, we could identify opportunities for our staff to be placed in these neighborhoods so that they could have easier access to the service provide. This was 2019, and so this grant allowed us to hire outreach coordinators who at the time had not been named. Of course, 2020 happened and COVID-19 happened. And of course, as with other organizations, whether it be a community-based setting, we were impacted tremendously. And so we had to get creative and we into transition to a virtual approach in connecting with as many communities as we could over this time. And as we here in county, we started looking at it from a preventative. Okay, at the point
James, I'm sorry to interrupt you. I think it might be better if you turn your video off and then your audio might be
okay.
Thank you. There you
Is
go.
that better?
We'll try it.
Is that better?
Yeah, actually that is better. Thank you.
Yeah, there we go. Great. We started really looking at our mission a little bit differently at Cancer Care Services, understanding that COVID-19 really kind of peeled back the layers on disparities as they relate to the social determinants of health. And we started reimagining of how we can connect with community members before they are impacted by cancer. There were studies and data that was coming out saying that because of the COVID-19, we're looking at a wave of late stage cancer diagnoses, stages 3, and this trend was really going to impact our medically under. So, as things played out organically, we were actually able in 2021 to enter into a research partnership with the UNT Health Science Center. And to give you a little bit of background, there are significant health inequities pertaining to cervical cancer incidence and mortality in the Hispanic community in Tarrant County. And we have a healthcare system in Tarrant County that is limited for underfunded or including individuals with a lack of documentation status or lacking documentation status. So limitations in access to healthcare, inability to obtain cancer preventative screenings. And so to develop a plan to create deliverables to promote an awareness of health in communities, specifically around cervical cancer. And then we saw programs to promote health literacy and preventative services in what we shared accountability and collective impact model. And so because of this project, it actually led into to a community health screening pilot. And so once again, realizing that due to the extreme decline in cancer screenings caused by the coupled with historically low screening rates within minoritized communities and populations, we sought to facilitate free ongoing screenings in collaboration with strategic partners. Those strategic partners, Brief Cancer Institute, Texas Health Resources, and the Black Foundation. And then transitioning to 2023, we scaled the work that we were doing in the community with community health workers through a strategic partnership with UMember Health. They provided us with a CHW training curriculum, which also would an oncology specific module to build the skills and competence that CHWs would need to promote health equity, reduce health disparities at the personal, family, and community levels. And this essentials curriculum would align with national standards and is very versatile in the fact that it can be used in diverse settings with diverse learners, in person or virtually. Next slide. So, a little bit about how we're funded. You can look at our funding in terms of pillars. The first pillar is really centered around foundations and grants. And here I have highlighted and one government grant that we recently applied for. The Texas Women's, the North Texas Community Foundation, as I mentioned on the previous slide, and also the Cancer Prevention Research Institute of Texas. We're using this particular government grant, of course, to our screening initiatives with our partners in our community, and use the grants in part in 1 to 2 year cycles came in to hire part-time and supplement full-time staff. And at the outset, that is kind of how we were able to get community health workers into our organization. We then transitioned our CHW workforce into sustainability model. Next slide. So this sustainability model, known as Benavon, was developed by Terry Axelrod. So the Benavon model is a systematic process for sustainable funding by engaging and developing relationships with individuals and donors who love our mission. Previously, what we looked was to host an end-of-year gala to raise money for our organization to continue funding our programs and our initiatives. How this model is not about that. It's about putting on, it's not about putting on little events, but it's about putting on big events and not putting on big events, my apologies, but it's about engaging and developing deep relationships with individuals. And what we look at with this Benavon model is a 4-part process. The first part of the process is the point of entry. This point of entry, also what we call our Heroes of Hope tool. And so this is an opportunity for my community members to learn about our organization. And through this, we're able to identify potential members who would then host additional tours and bring in individuals from their network into our organization. And so part 2 of this sustainable funding model is about follow-up. And so we have a team that reaches out and connects with individuals that have come through this tour pipeline to, one, identify potential ambassadors, but see how they would like to engage, with our mission. And as we hold these tours, these points of entry, as we follow up with individuals through the points of entry, we are then looking at our ask. And like I said, isn't a gala, it isn't some huge event. It's a 1-hour luncheon where we try to secure multi pledges to fund our programs, to fund our CHW initiative. And then from there, our multi-year pledges, those individuals who are then part of our Legacy of Hope Giving Society, as we call them, continue to build that relationship by introducing them to some of the events that we have, getting them to conceptualize where dollars are going, where their donations are going, and then we do it all over again. And we look to Hope Giving Society members to continue to make introductions, and we try to facilitate new introductions as we go through this cycle year in and year out. So, next slide. So, because sustainable funding model, we have actually been able to increase our revenue by 260%. Now, this is compared to our previous with the Joy of Life Gala. In terms of average net revenue, there has been an increase of 38% in our sustainable funding. And so to really kind of bring it all together and tie a nice little bow on things, realize that through our current sustainable funding model, relative to what we used to do with our gala, it would take 16 years of gala equal the net revenue, 7 luncheons. And so this is a model that is based on storytelling. It is a model that is based on relationship building, and it speaks to on a macro level at our organization how our community members are connecting with our CHW. There's a shared lived experience between our community workers and our clients that we're serving. And then it is about relationship building. And so our sustainable funding model, what we're doing in the community. And so our ability to harmonize the two is going to really continue to allow us to expand and scale what we do with our community health work here at Cancer.
Oh, sorry, James. Did I cut you off early?
No, you're good. Here's how you can reach out and contact me. The floor is open.
Great. Julie, I'll invite you back on.
Thank you so much for providing such great information. I was speechless to learn about the organization and how you are able to provide services to the cancer patients that have no insurance or maybe no way of paying for their treatment, their support. I think that your entity is one of the first ones that I hear of that does that. And the one thing that I really like, James, is that for the people that live outside your county, they call your center and you don't just turn them away, but you try to assist them to refer them to where they can get the support that they need, either for their services or their treatment, whatever it is. And that's really wonderful. Thank you so much. And I'm so happy that y'all are in Texas, because it's easy for us to remember your name and also how you are able to bring in all this money just based on the storytelling that your organization creates along the way with the support of the community health workers. So thank you so much. Does anyone have any questions for Mr. Earl?
Mr. Earl, I have a question. I'm wondering how you found the Benevin model and if you had tested other models first, other than the Gala model. I liked hearing that that story of how you switched, but how did you find the Benevin model?
I believe there was another organization that had implemented here in Tarrant County before we had, and members of our had a relationship with someone from their organization. And so it's a natural progression of conversations. They felt that this would be a model be very impactful to fundraising here at Cancer Services. And so we implemented them, I want to say, for the first time in 2016. Yeah, and so we've been doing it for close to 10 years.
We have a question, actually two questions in the chat. One of them is, can you elaborate on what you mean by storytelling? And it's an excellent presentation.
Yeah, thank you, Marianne. And so with our point of entry, our Heroes of Hope, is we use a storytelling model that our CEO, organizations like our social workers, our community health workers, and then we also use clients. And these different stories actually fill three distinct buckets to emphasize in our organization that have a need for funding. So this storytelling really creates an emotional hook and investment for people who are coming through the point of entry. And so we are then able to tell our mission and really communicate our mission in a way that is impactful. Just, inviting someone to a gala and saying, hey, give me your money. Storytelling creates that emotional hook. That emotional hook then allows us to continue to build relationships, and relationship that we build, over the course of the year during, then allows us to make this act.
Thank you so much for that additional information. Then there was another question from Andrea Casas about resources on that model, and Shay went ahead and uploaded a link there on the introduction. I believe we all like the storytelling model, and thank you so much, Mr. Earl, for your time and for sharing your knowledge with us. Does anyone have any other questions?
There's one thing I do want to emphasize, Dr. Julie, is we do provide assistance and services for clients regardless of their documentation. So I want to emphasize. And we have a staff of, I want to say, close to 8 individuals who are bilingual.
Thank you so much. Shay?
Thank you. I think as we wrap up, I just want to make sure that no one has any other burning questions for either Mr. Earl or Dr. Schlenker, or for Julie and I as collaborative members.
Internet has next level speed. Get 1 gig internet for as low as.
All right, then I will wrap up. Let me just pull up my final slide.
Can I say something?
Yes, please.
I just wanted to commend Julius, the presentation, especially again emphasize the story. It is the story that moves us. And that's the same thing that happens here. You tell the doctor the story of the patient, and that doctor's care is going to be activated into more, wanna know more. So I was happy to see the confluence of both of us in what drives. I mean, you care when you hear the story, that emotional hook that you're talking about. It's our shared humanity. Remember the parable of the Good Samaritan, right? We have the capability of solidarity in us. We don't need to be driven by something that does not count with us having solidarity. So again, thank you for emphasizing that, because I think that's where both of our programs coincide as to what is it that the promotores and the CHWs bring.
Yeah, and one thing I also want to emphasize too is, although we are a community-based organization, for our clients that we serve, there is no distinction between us and a hospital. None at all. And so, the approach is very similar about how we have to connect and how we have to relate. And so that is one thing that, I talk to my team about all the time. Like, Cancer care services in the eyes of our clients is the same as JPS, is the same as Texas Oncology. There is no distinction. And so we really have to keep that in mind in
Yes.
terms of building that trust, telling those stories, and building the relationship that we need.
Right. And
I
our
love that.
doctors our doctors are aching for not being able to get the story in their frameworks of workflow. So they want the story. They're just structured in a way that they cannot get it. So again, we need to change the structures. But thank you so much.
Thank you both. And I will be gathering all the resources that were put in the chat box and mentioned and sending that out to everyone. And I know you, and at least Mr. Earl, you had shared your contact information, so I'll share that as well. So just to wrap up, if you want to get involved with the collaborative, either if you're a CHW employer or you want to test the waters with employing CHWs, as a part of our program, we can help you host interns or apprentices. But if you have questions about employing CHWs, still send them to me and I will try to connect you with the right person. Our next webinar will be on the impact of CHWs, to talk about the return of investment, and which is not a new story, but it's always helpful to share, and also just talk about individual stories of how CHWs have impacted both people and hospitals' bottom lines and health equity in the community. And then finally, please take our survey, give us feedback, tell us how you want to get involved, and that would be great. Thank you, everyone. And I will be sharing everything later this week.
Thank you.
Thanks, Anel.